and John will be joining shortly. Good afternoon. This is the Kern Valley Healthcare District Board of Directors meeting for Monday, May 9th. This meeting is called to order. Item B on our agenda is approval of the agenda. Are there any changes that any board member requests?
I'll make the motion, we accept the minutes as presented.
Jane,
Not minutes yet, just
Oh.
agenda.
Agenda.
I'm sorry.
I'll take a second if there's anyone who wants to second that motion.
I'll second, Ross.
Thank you, Fred. Jean, your vote.
Yes,
Fred, your vote.
Yes.
Catherine, your vote.
Yes,
And I'm a yes. So at this time, we have a flag salute. So Tim, if you could lead us in our flag salute.
Sure.
And Catherine, can you lead us in the invocation?
I can. Hear me okay?
Yes, we can hear you great.
I pledge allegiance to the flag of the United States of America and to the republic for which it stands,
On cultural side.
under God, indivisible, with liberty and justice for all.
Thank you, Tim. Oh, that's right.
If you guys remain standing. Lord, I just want to take this time and come before you and thank you for all the things that has been happening at the Kern Valley Hospital. Lord, I just ask you for the progress that we continue to make. And I ask that you just be with us as we have lots of things to make come true ahead of us with the building and different things going on. I just ask that with your support that we're able to meet all the needs of the community. Ask all these things in your name. Amen.
Amen. Thank you, Catherine.
You're welcome.
And our mission statement is here on the agenda for all to review. Item C, public comment. This portion of the meeting is reserved for members of the public to address this board on matters that are under our jurisdiction, but not on today's agenda. Are there any members of the public that would like to be heard? See no one coming forward. Then we'll move to the consent agenda. Item D on our agenda, there are 18 items listed for consent. All of these are considered non-controversial and routine. They'll be considered in one motion unless a member of the public or a member of the board would like an item removed from the consent agenda. Any board members request an item be removed?
make a motion, we accept the consent. I do that, I make the motion because I want to just move on. 'cause
That's
it
great.
needs to be
Yeah.
made.
It moves it along. Thank
Yeah.
you.
I have one modification to it, and that would be on number 7, contract reviews. This is Tracy Langenfeld, a microbiology consultant. I don't believe that contract is needed anymore. So I wasn't here for the finance committee to take it off. But I think we can cancel that.
So
Just
we can
remove that.
remove that one?
With it, yeah,
Okay. Hi, John. Please have a seat.
Hey, Jim.
but otherwise I'm good.
Okay, so 7D is removed from consent table,
Do I need to revise my motion?
probably.
Okay, except
With that
as
modification.
modified.
Thank you.
Thank you.
Do we have a second?
Second, Ross.
Thank you, Fred. Were there any members of the public that want an item removed from consent? Okay. And Jean, your vote?
Yes,
Fred, your vote?
Yes.
Catherine,
Yes,
do you want to vote on this?
What are we on?
Consent? Consent?
yes.
They look pretty straight.
Thank you, Catherine. We are item 7D, item 7D.
Give us some feedback.
Okay.
Give us some feedback.
Hey, Catherine, we think there's feedback coming. Catherine, we think there's feedback coming.
How about now?
That's better.
I don't think we're hearing anything now. That's good.
That's good.
Okay. All right, so, and I vote yes on the consent agenda. Did you want to vote or abstain on consent?
Oh, I looked at it before. I'll vote yes.
Okay, all right. Then we will move on to item E, the reports. And the foundation report, I think Debbie Hess is going to give her report from in Spanish today.
She here?
No.
Having gone, there was actually.
She's on vacation. I don't see anybody else. Was there anybody else that was going to present?
Not that I'm aware.
Okay, all right. Then we'll move on to the auxiliary report. This is Rupert.
Thank you. Good afternoon, everyone. Thrift store is moving along really good. I want to thank the hospital and the board and the administration for the lovely luncheon. The food was awesome. The fellowship was great. We had a wonderful time there. I haven't heard any complaints. And like I said, the thrift store is moving right along. Waiting for everything to come under control. And can't wait for it to happen.
And we're working on policies and procedures. right now, so-
I understand that. If she has any questions, she can contact.
Absolutely.
And I said that I would continue on being the liaison for a while and get somebody to be trained under me so that they know what the runnings of the store are. And so we'll see
Great.
how it all works out.
Thank you, Cindy.
Thank
Thank
you.
you. And I need to get back to work.
Are there any questions for Cindy before she leaves?
Have a good day.
Thank you.
Thank you.
You too.
Cindy.
See you soon.
Okay, our medical staff report. Hello, Dr. Finstead.
Hi there, Ross. So let's see, so last month, the Pharmacy and Therapeutics Committee met on April 6th. We discussed old business items, including COVID-19 and the recent survey. We reviewed and discussed a number of policies. 3 of them were approved, and 5 of them are going back for changes. We approved the ones regarding temperature monitoring, panic values from the lab, and infection control, materials assessment. 3 policies are being returned. They include high-risk medications, some sterile compounding issues, and similar items. We also discussed recommendations from the Institute for Safe Medication Practices regarding how orders should be written for as-needed medications. And then we reviewed our regular reports on the medication error reduction program, medication shortages, temperature alerts, MRSA monitoring, and hand hygiene. We also reviewed antimicrobial stewardship and procedural sedation. Then the Antimicrobial Stewardship Committee met on April 12th. We now have our infectious disease specialist on board, Dr. Phil Lizarda, who is just joined the meeting for the Antimicrobial Stewardship Committee. Discuss processes that would improve antimicrobial stewardship, including when antibiotics are written, that in the EMR there needs to be an indication or a reason for that. That has now taken place. That's basically a hard stop in the order writing process. So without that, you can't really move forward. Things. So that's definitely a improvement. That's been a very long-standing process for the skilled nursing facility. You can't write any medications without a reason, but not so for acute care. So that's some progress. They also reviewed the antibiograms, which are an analysis of the actual infections that we have, the bacteria that we have, and which bacteria are resistant or sensitive to which antibiotics. Reviewed the one from the first quarter, and it was noted that we don't have a lot of resistant bacteria, which is good news for us and particularly for our patients. Also reviewed their regular and new reports. regarding hospital-acquired infections, antibiotic usage, and things. And then the Medical Executive Committee met on also on April 12th. We reviewed and approved the above mentioned policies. We also discussed the recommendations from the Antimicrobial Stewardship Committee. So that will be a regular report for Executive Committee to be monitoring that. Also reviewed and approved a list of emergency compounded medications, which has been in place, or this process has been in place since November, and is updated as on a regular as needed basis. Then the Infection Control Committee met on April 18th, reviewed their regular reports along with the new reports regarding antibiotic usage for pneumonia and lower respiratory tract infections, along with urinary tract infections. Also reviewed the regular reports consisting of the hospital-acquired infections, blood cultures, hand hygiene, Foley catheter usage, both in acute care and the SNF. And then finally, the Utilization Review Committee met on April 27th and discussed issues regarding denials of payment and authorizations for admission. Also discussed issues with average length of stay. Some of the issues that impact this are have been COVID, needless to say. Also, we get patients here that get admitted and there's just not, there aren't the resources for them to be safely discharged. So they end up staying here until we can make arrangements, particularly get work with that process through the insurance carriers for these people. So we have some people that end up being very long-term patients here, unfortunately. And then they reviewed their regular and annual reports regarding medical records and utilization review. And that's the end of my report, unless there are any questions or comments.
Board member, any questions? Dr. Prince, I don't know if I could read between the lines. Are you referring to the issue with QualCare that was identified last month? Is that still a problem?
So I do not have those details. That's a committee, fortunately, that I'm not on. So that's the only report I have. So you may have more information about that. I just have heard anecdotally that that they are very difficult to deal with. And once they have, or we have a patient of theirs and need their assistance, it's kind of good luck. Tim probably knows more about this than I do.
Yeah, I can give you a little bit of an update on that. They are, we've had some ongoing conversations with them.
Have you found the people to talk to?
Yes.
Good. Okay.
Well, and I think that Vince Vaughn was a help in that in some regards, because literally the day after we spoke with him, they started calling us and stuff like that, so which was interesting. But there was an article that was just written last week that came out on a lot of the Medicare Advantage plans are now being monitored by the federal government because they have been arbitrarily denying care, when patients qualify for that care. And so they've got several plans that they are closely monitoring right now. And so, again, I think, in our conversations that we had with them is, listen, these are patients, these are benefits that you're responsible for providing. Medicare is a covered benefit. The patient meets the needs and so forth. It's your responsibility to work with us to get this patient where they need to be. And so we've shared that with our utilization review staff that, if need be, then we have no problems with calling Inspector General and having them investigate to find out, whether or not this is justified or not, the actions they're taking or not taking, and so forth. So I think we reviewed this with Dr. Gross. And I think we were all very comfortable that this might be the solution for us, just to we know that they're being monitored and so forth. So we're not threatening anything. But the point is, if we've got patients that are not being addressed and not being cared for, just say, hey, we have an obligation to let the state know and the government know that their needs aren't being met. So
Good.
instead of it falling on us. So
Yeah.
we'll see. Like I said, I was pleased to find out this morning that the patient in question that was behind all of that is actually went somewhere this weekend. They were moved to another facility,
Oh, good. Oh, well.
but not through QualCare's.
Not as a result of the insurance, though.
Yeah, right. It's for some unknown reason, no one has any idea how they, with a caregiver or some other one took them and got them to a long-term care facility that they needed to go to.
Okay, well, that's good.
So anyway, it's, but yeah, we have a strategy now in place that, from our communications perspective as to how we're going to get that word out to them. And so
Okay.
we'll see how they respond.
Good,
So,
good. I know that hospitals and hospitals don't like to threaten each other.
Right.
With going to the oversight bodies, and it's probably the same with the skilled nursing facilities. But if we're dealing with an organization that's not playing by the rules, don't hesitate.
yeah, oh yeah.
That's why they're there.
Right, exactly. And like I said, this was not a plan affiliated with one of the other hospitals. It was Humana. That was the issue. I mean, there were the agency or the insurance company that was really creating the problem and so forth. So like I said, we are aware of it now. We're alerted to that, and we kind of know where to go
Right.
and how to get movement. So
Thank
we will
you.
continue to monitor it. We'll report back to the board.
Okay.
But it was QualCare.
It was like
Humana
QualCare group.
contracts with QualCare, so does
Right.
Blue Shield
Yes.
and Blue Cross, so they all contract with them.
Right.
And so QualCare is the one
Yeah.
that's not doing what they're supposed to. It's up to Blue Cross and Blue Shield and the other Humana
Right.
to make sure they are.
Right.
So it's a,
Yeah. Two-way, like I said, because the insurance, ultimately, if you get on the insurance companies, they're going to be pushing the group to make sure that they get
Yeah.
it done. So, and they're not shortchanging the patients.
So that sounds like pretty significant progress. I mean, we have had problems for years with a different group in Bakersfield who would not allow patients to be admitted here unless they were admitted under observation. Things that's improved some recently, but there are definite guidelines which make an appropriate observation patient and which are appropriate inpatients. And that has been an issue, maybe not quite as much now, but I think it still comes up pretty frequently when we call for authorization. They'll say, no, just put them in as an observation patient and things. And patients get the same care, but we don't get the same reimbursement.
Right, exactly.
The trouble is, if they deny that, or if they don't authorize that, then the patient becomes liable for that admission, correct?
I don't think so on a Medicare.
but isn't there a difference in care, Mark?
Not at all.
No, we don't.
Matter of fact, we might do more work for them in the first day.
Right,
Yeah, what I was told was they just have a bed there and they don't really have a nurse or anybody monitoring, they're just there.
not at all.
That's
No,
not
we
true.
handle them the same way we do the other
Then
inpatients.
you
Yeah,
should we should get it paid
Right,
the same way.
right.
And Gene, from the medical point of view, they get exactly the same care from the hospitalists as acute care patients. I mean, the paperwork, the documentation, everything is exactly the same.
Yeah, we'll fight the battles.
They just found a workaround to not pay us.
Well, we're taking care of the patient because that's our responsibility. So, we'll hammer out the payment issues afterwards. So,
Anything else, Dr. Finstead?
No, I don't have any other information.
Thank you. Thanks for being here.
My pleasure.
Okay, then we will move on to our Chief Executive Officer report, Mr. McGlue.
all right, thank you. Another meeting with the grand jury. This was a telephone conference, which actually was their exit conference with us. It went very well. It was about a 15-minute meeting. They really just kind of wanted to recoup what will probably be in their report. There are about 9 items or statements that they made. Just wanted to validate with me that those were accurate or, valid statements they were making. A lot of them had to do with the construction, wanted to see Again, that when we start the building, that we're going to have a construction or project manager. I said, absolutely, that's not going to happen without it, things like that. One of their recommendations was that, again, we go back and relook at the pricing on the building. And I said, we're already ahead of you. There's a motion or a thing going to the board today, asking for us to go out and get a new company to come in and review the pricing on the project so that we'll make sure that we've got the money. And again, I reiterated the commitment to the board that we're not going to start any phase of this project unless we know the money is all there before we start doing anything. And so they were very happy to hear that. We talked about just a number of other things that communications, things like that, again, very pleased by what they said. Is that we wish that all of our inspections were as nice as the ones coming there. And he says, you guys welcomed us with open arms. And I said, we realize, he said, sometimes we walk in and people won't have anything to do with this. So I just said, again, we're a public agency. We recognize that, who we serve. And I said, it's just really our intentions to, make sure that, we understand there's oversight that we have to comply with. And so we welcome that and any ideas that they can help bring to make it better. So nice time. Again, the plan of corrections that from the last walkthrough, the survey that we've gotten had been submitted. And so we're waiting still to hear back from them and how that will go. It was pretty detailed. And so that's, again, we're just kind of in a wait mode right now, which is typical of what we've gone through with the survey. But again, we continue to work on all of the items that we identified in the original plan. We've been working on all of the temperature issues that we had originally. We now have the air conditioning system out here for the pharmacy. That monstrosity.
Yeah, man,
It's as big as the room.
It's almost as big as the room.
But I tell you, Bob showed me the numbers this morning. It's literally for the last week, it's held the temperatures right where they need to be. So that's working well. And we were able to, Bob was able to change some things that helped bring down temperatures in one of our supply rooms. That was actually one of our largest, our station that had the most alerts temperature wise. And since that time, we've not had one hit on that probe. So it's been working great and getting a lot of these things taken care of. So anyway, that work continues, like I said, but we'll continue on. We'll see what they say. Again, I'm just really focused on the plan of corrections, the antimicrobial stewardship work that Dr. Finstead talked about before is a great part of that, and making sure that we are spelling out in great detail within the minutes, which is why Dr. Finstead was as detailed as he was, to make sure that communication gets through to all the various medical staff committees that need to know that and so forth. Mark will talk a little bit more about that later. We let me see here. Oh, we donated the patient transport van that the board had approved for disposition last month, and that was donated to the ARC, the church in town. They must have had 15, 20 people out here. We did a picture thing out front and handing over the keys and the pink slip to them, and they were, of course, while we went out to start it up, its battery was dead.
Oh, no.
Hadn't run it in like 3 weeks.
So we had to go get them.
We had to jump it.
They'll put some good use to it.
I'm
so
sure they
that's
will.
Awesome.
I'm sure they
So
will.
good.
They're very appreciative.
Sure.
Everybody's really excited.
Definitely. So, and their mechanic is anxious to get his hands in there and get this thing all fixed up and working for them. So he said they got lots of plans for it, and lots of needs. So they were thrilled to have it.
Cool. Thank you for doing that.
You're welcome. Again, we're continuing on with our physician recruitment efforts for the clinic. Greg has been working very closely with one particular candidate, Dr. Solms. She will not be available until next year. She's finishing up residency right now and so forth. But well, and we'll wait to see. We still have some negotiation issues if we do decide to go with her. But in the meantime, we're going to continue looking at other candidates as well, just to make sure that we get the best we can. Working with the hospital association, working on a letter to support SB 1339. This is a bill that was put out by Senator Pan. And the purpose of this bill is to amend, CHA is supporting it as long as it gets amended. The bill itself is calling for an inventory of all of the hospitals that are currently working in an SBC 2 level facilities. They want to list OSHPD or HCI is supposed to provide the legislature this list by January 1st of 2024 of all hospitals statewide that have where patient care is being provided in the SBC 2 facilities. And they also want them to provide a list of all of the services, clinical services that are being provided in those buildings. And then they are expecting that HCI will tell the state how much it's going to cost to upgrade those facilities. And of course, I'm curious to see how the heck they're going to estimate that.
Yeah.
You know, I mean, excuse me. Gene check.
We'll come back to you.
Hi, Gene.
Hey,
How
Mark,
are you doing?
can you start
Yes, sir.
giving us the chief nursing officer report? We'll come back to Tim when he's back.
Absolutely. Well, good afternoon, everybody. I wanted to talk about, we're starting up the HSS training again, and there'll be the hands-on training for the nursing staff and for the security staff. This training is there's two components to it. One is a LMS component. The other is the hands-on component to kind of break holds if a patient were or a family member were to grab a hold of someone. This is kind of like self-defense and getting out of the way kind of thing. Also de-escalation strategies for security issues. So that we're excited to get that going again. Since COVID, we haven't been able to have those classes, but we're going back. We have hired a few new nurses in the past few weeks, which should help us move away from the travel nurse registry service. Dave might find that he'll be happy about that one. The trend for COVID positive cases in April was just a little less than 1%. The May numbers are looking like we're around 2%. I don't think there's any indication there's a trend. It's just the volume of patients. I still think I see one a day, and they're not being admitted. Our last admission to the hospital from the ER from anywhere was discharged on April 26th. So we haven't seen any COVID patients admitted since then. So we're happy about that too. The transportation service is currently providing 5 to 6 rides per day to various appointments. We have a second driver per diem status for when the load is heavy or appointments are too close together for one driver to get them both. And the last thing, when we were alluding to what we were doing with the plan of correction, we put together a binder that has updated minutes and updated information in it with respect to every tag that was identified, so we can keep that current. So when a surveyor was to come back, we could hand them the binder and then they could go off of that to say what else they might need to see. So that's that was the latest thing we did with respect to the plan of correction. And that is the end of my report.
I have a question for you, Mark.
Sure.
Where'd you find the nurses? Where are they coming from?
There are a couple who are new grads, but one of them that was working for KMC, she was working for me per diem, and now she just decided to come on board full time for us. I just interviewed one from Ridgecrest yesterday, or I'm sorry, was it yesterday? No, it was last Friday, I believe. But we're making her an offer as well. We do have 3 candidates for the infection preventionist position that's going to be coming available in September. And I want to get somebody on board as soon as I can for that. Yeah, otherwise, yeah, it's just kind of, when I went on vacation, we got all these interviews to do. So I petitioned for going on vacation more.
Maybe that's,
Nice.
yeah, just let Sarah do the recruitment and you just sit back and go on vacation.
Not me.
Any other questions for Mark? Okay, thanks, Mark. Okay, Tim, I'm dying to find out what your compensation is like.
There's still a couple of items that, there's a big improvement and so forth, but there's still some items that say they want to go over. So Mark and I, we've been invited down to Gene's office on Friday morning at 10 o'clock. Dr. O'Bear is going to meet us there and we're going to work through it and get it all knocked out.
Sounds like a delightful day.
So they figured they're going to leave, give us till about 2 o'clock. So it gives us about 4 hours to kind of go through everything with them. So we'll be bringing that binder with us, obviously, to show them the progress that's being made.
Yeah.
So anyway, that's so anyway, just kind of finishing up. Again, this was this SB 1339, which was to go in and begin inventorying all of the costs and buildings statewide where services are being provided in these SBC2 facilities. CHA, as I indicated, is willing to support that bill to do that, but with modification. That modification is geared towards making sure that there's an effort made to restructure the focus of the original seismic regulations to only focus on provision of emergency services, and that all hospitals would ensure emergency services are fully functional after a major earthquake. So they want to refocus the standards on those emergency services and then propose an additional 7 years in which to meet those requirements. And so we'll see where that goes. So I've written a letter in support of that from our facility. Again, next the cabinets are going into the clinic this coming weekend, which will hopefully finish up all of our remodel project over there, and will hopefully give us a nice common look through all of the exam rooms and so forth over there. So we're anxious to get that finished up. Then obviously working with Dave on budget preparation meetings and so forth. And the last thing I have really is working on, we've got some ED physician recruitment. It looks like we're going to have to do. We've got our one physician who's announced that he's looking to retire here shortly. And another physician who's planning to take 6 months off and starting in December. So he's given us some lead time notice, but he'll be come back the following June. He's just got some personal projects he wants to attend to and so forth. So anyway, so we're looking at some solutions and opportunities to bring in a couple more physicians in. So to help bolster up our group there. That's my reports.
Thank you. Tim, could I ask you a question?
Sure.
Just your opinion. There's different committees and different
Yeah.
stuff and HR and inflation.
Yeah.
Our employees are going downhill. They're going backwards. And
Everybody.
what,
is,
what do you think we should do?
It's hard to say. Like I said, everybody is being impacted. All businesses are being impacted, and that's the economy right now is tough. Gas prices are up, skyrocketing. Prices for food are skyrocketing. Some places there's no food at all. You're looking at what's going on with the baby formula and stuff like that that's going on out there right now. Then you got inflation built on top of that, like you said, and it's a nightmare,
Well, but we'll start losing people quicker than we are now.
Yeah,
And it's gonna be a
and I
problem. We need to deal with it.
The issue is I don't know where those people are going to go, because no matter where they go, they're going to be impacted by the same thing. I think that's the problem and why we haven't seen that happening, unless, like I said, they're leaving for states like, New Mexico or whatever, or Texas, Nevada, where there's no state tax or those kinds of things,
In the budget, we should be considering a way,
Yeah.
and maybe a way to operate more efficiently. I know you're working hard to do it, but maybe we should concentrate on that area too, rather than
We're looking at that. We're looking at some benefit things as well, which we'll talk about a little bit later. Again, not sure how much those things are going to impact people's decisions. People still have to work. They still have to eat, and provide and so forth. So, again, I think we've probably done a pretty decent job for the most part of keeping ahead, again, with our salary wages and so forth. We've adjusted those, keeping ahead of the minimum wage issues and so forth. We adjusted a big portion of our staff up with regards to our CNAs and LVNs and the MAs and
A
some of these
lot
things.
of them people are gonna be retiring from here. I know
Yeah.
they've been here
Oh, sure.
longer
Absolutely.
than I have, and so we need to be in a good position as we can.
True. Well, and that's why I say Mark is working obviously on nursing recruitment and those kinds of things in all these areas. And some of our
If
non-nursing
we,
departments as well.
if we gave Dave a raise, could he make it better?
Shaking his head now.
All right, thank
I wish it was just the money certainly doesn't hurt. I know everybody's hurting and stuff like that, but the problem is at some point this hopefully will go away. And the point is once you commit those dollars, then, it's hard to take them back, And so unless there's some other means that, we can come up with something, but Dave and I, again, we're still working on budget stuff and maybe there's some things that we can talk about and we can bring to finance and chat some more about it. Be happy to do that.
Okay, thank you.
It's impossible to give an across the board increase
Yeah.
to keep up with inflation unless Medicare and Medi-Cal are gonna
Yeah.
bump up the road. just to
You're talking
support
about
that.
using reserves and those kinds of
Yeah.
things to do that, but you're setting
Otherwise
your
it's-
reserves aside for the construction,
Yeah.
so.
Well, we
It's-
can't fall apart, so we have to do something,
Right.
so, but
Yeah.
yeah, I think you're on one of the committees that's sort of engaged in that.
Yeah.
So, all right, thank you.
You're welcome.
So say did Barbara retired, but she's not here.
Yeah, where's Barbara?
like
No, but that's probably not too far off.
She's
So,
been here a long time.
yeah,
Catherine, Fred, did you have any questions for Tim?
No, sir.
All right,
okay, thank you.
all right. Then we will move on to our Chief Financial Officer report, Mr. Recupero.
Thank you, Ross. Good afternoon. And I'm going to steer clear. Gene, you raised a whole bunch of can of worms, and I'm steering clear all that for the time being.
Okay,
We're
thank you.
gonna go into the report, and somehow I lost my spot here. So I'm gonna go back.
Can you share your screen or?
Yeah, really, it's not, they changed,
Oh, that OWA thing.
Flying drones.
so I was, let's see. Maybe I'm bottom here. There it is. Okay. Sorry about that. Okay. So we're gonna start on page 22. And so we're 9 months, 3/4 through the fiscal year. Through March 21st, and I'm referring to the total net surplus here, which is the bottom line profitability for 3 months or 9 months, excuse me, 3/4, almost $3 million. So we're going to start out with this report as a real big smiley face. $3 million is a great number. Typically, that's about what we make in a year. So we're really ahead, as you can see, way ahead of budget, 545. That's going to be probably the only positive comment I make the whole presentation, because the last several months where some new things are popping up that makes us shows us that we have areas of improvement to tackle. And one of the things to point out as we look at page 24 is just the cash all sources, this new category where we're adding up all the various line items that constitute opportunities for either normal operations or the construction project. That number at year end last year was 29,397,000. So even though our bottom line looks better, our cash has gone down by about 3 million. Now, I'll just tell you the main reason is the IGT difference this year. We knew that was not a surprise, and we'll be showing you a report in just a little bit to show you almost identical amounts going the other way in terms of a reduction of IGT payments that have come in this year so far. The next thing I want to talk about is that $3 million bottom line. I want to refer you to line 20 on the liabilities, the long-term settlements on page 25. And you can see a year ago at fiscal year end, that number was 14,302,000. It's about 1.5 million less, which means that what we were able to do this year is take 1.5 million of what we thought we owed in settlements and put it to the bottom line. So another way of saying that is about $3 million of our 1.5 of our $3 million is prior year adjustments, about half of it. And that's the difference between the 14.3 and the 12.7, to show you that that's how much less we're showing in the liability section of what we think we might have to pay back. The next thing I want to move to is showing you the trend in how our operations have been going the last several months. And the best way we can show a trend is to go to this page here on 28, where we show each month going backwards, starting from the most current month on the far left and each month before that. What we can see as far as a slightly deteriorating picture is revenues being higher 6 months ago and getting less, and expenses, especially salaries and wages, starting out low and getting higher. So we definitely don't like that as a trend. What we'll see later is the whole aspect of productivity, and you can see we're underperforming in that area as well when we get to that graph or the table. But overall, what we wanted to show you here is that we have this where we started out the year real well. However, the last several months, things are showing signs of deterioration in terms of bottom line performance. Now, we did also book an extra 200,000 on this line 30 in the non-operating. That's not so much third-party settlements as it is that COVID money that now we know we won't have to pay back. So over the last 5 months, I'm moving in total $1 million over to the bottom line that we know for sure we won't have to pay back of the COVID money. So that was another 200,000 put in for this current month, showing us the total for the month of almost 700,000 total net surplus, which includes that 200,000 of the COVID grants that we showed coming into the bottom line. The next thing I want to just briefly summarize is what I was talking about earlier, moving to the ratios, this ratio on line 29, FTEs per adjusted occupied bed. So that's typically what the industry uses to evaluate productivity for healthcare facilities. Critical access, you want to lower the better because the numerator is an expense number. So 5.8 is what the average is for all critical access hospitals. Last year we had 5.58, which is better than average. However, you can see this year so far, year to date, we're over 6. So we clearly have not performed as well in the area of productivity.
Look at the, Dave, when you look at that same number, take a look at line 23, because that adjusts for the outpatient factor. And so while we've seen an increase, obviously, in the per bed fee, when we factor in the outpatient side, we're actually at 4.97, which is below the 5.86. So still a little higher than where we were, but it certainly helps.
Good point. So that's a good point just to balance out the picture. It's not all bad, but I clearly am getting nervous, especially when I looked at our budgeted requests, which was 22 FTEs higher for next year. So I guess my mindset is mostly looking at where we need to be careful and not so much applauding ourselves. But that's other meetings. We are making progress. Tim put a very aggressive list together of like 13 line items in the budget that have been requested that are being reduced back down closer to where the prior year numbers are. So we're right in the process of going through that tough work that we have to go through to make sure that we don't all of a sudden slip into being an organization where we're scrounging for money and we're looking at deficits. So I just have that little higher level of urgency right now until I can see that we're all on the same page. We've got a lot of good ideas on how we can spend more money and hiring more people, but it doesn't always translate to the bottom line. So we just have to be careful. I don't have anything else to say for this meeting, except that we had a very successful, I was really proud of our departments. There were like 4 or 5 departments that stepped up. We had a little crisis earlier in the month. I got a call from a Medicare auditor on the cost report for the 2020. And she said, Kern Valley owes $600,000 and we weren't expecting any of that. And she went into the detail of where they were citing our deficiencies on how the cost report was filed 2 years ago. We got specific instructions on what we could do to fix it. It had a very tight deadline. So I got medical records, housekeeping, social work, nursing administration. We all had to do special time study reports going back to 2020, showing it's called a B1 statistic. And thankfully, that 600,000 settlement went to less than 100,000. And of that 100,000 settlement, we can recoup that in future years by changing some of our practices on Medicare bad debt, that we could recover that same amount by resubmitting in future cost reports. So I was really pleased with the team effort on how we came through and got the deadline. And third-party settlements, as you can see when I was showing how much a part of our bottom line that is that's another part of financial management, is managing those settlements. That's it.
You said that was it, right?
Yes.
I got one question or one statement. I hope we're not paying you what you're worth.
Well, I think you got your money's worth out of me this last month. It was a challenge, and I was glad it turned out. And again, it like a lot of other things, it's not one person. I could never come close to doing what I do without Barbara. And I hope you all realize that she's a really important asset for our
We missed her.
organization.
We were all talking good about her. She's.
No, she's not here. Does Whipley still do our cost reports?
Yes, and they apologized on that one. That one slipped by them, that error that they caught. There was a way, I guess Chet could have appealed that a couple of years ago and somehow we missed it. But unfortunately, we had a good auditor that was willing to work with us and let us get caught up on what we had to do.
Okay.
I don't know if Paul was still, does Paul still do anything with cost reports received?
Paul is still kind of in the sidelines. We're going to use him when we need to. He does have some expertise that we might need down the road, but mostly Whipley and Rick Jackson and District Hospital Leadership Forum. We use most of those folks for consulting as it relates to reimbursement issues.
Okay. Yeah, Paul's a really nice guy.
Yeah, he is.
I just had one, but maybe it's too premature to say this. Looking at our financials of last year, I mean, we've been doing very well, I think, from both a cash perspective and a net profit perspective. I mean, we've actually exceeded some expectations. David, what do you think going into the next fiscal year? Are we going to probably see some of those same trends, or is it going to be kind of status quo, and also take into consideration how the state pays the hospital with the IGTs? Have any perspective on that looking forward to the next fiscal year?
Good question.
You don't have to answer. You can answer after.
I try to.
I don't want to put you on the spot.
I try to zero it into the things that we can control. And the things we can control have to do with discretionary expenses. And right now we're trying to move the dial. The requested budgeted increase in expenses is 8.5%. And we need to get that number down to like 3.5%. If we're not successful, I'm not as optimistic about next year if we can't get those expenses down. That's really all we could control. We really need to get the skilled nursing back up to where it needs to be in the 50s. We need to get the GI program and the other surgical areas going again. So in the absence of growth, it just boils down to really tightening the belt on the expense side. So I don't know if that's the answer you wanted to hear.
The skilled nursing, Dave,
Yeah,
in the past, when we were smaller and weren't dealing with as much money, 67, if it went below that for 3 months in a row, they fired the CEO. I swear to God.
well, we really need to take it seriously and
We're
not.
talking about 50s. The minimum should be 67.
We need to take it seriously and never put ourselves in the position where we can't take a patient because we don't have enough staffing.
Right.
So I'm hoping that we can take that seriously and put a plan together so that doesn't happen again next year.
Well, the board has said they would volunteer to help staff that skilled nursing.
I don't remember the conversation.
Mark, can you share that with Sally?
So those are the
I'll pass on their phone numbers to.
those are the kind of things that keep me up at night. And, as you can tell, I'm not satisfied.
Gene, tomorrow night, there's an open shift.
Catherine, did you have a question?
I do. So in the process of taking this seriously about the skilled nursing, I mean, when do we say, you know what, we're going to have to pause this building until we get that nursing facility filled up to make, or a budget or above, so we can continue our building plan
We're
or
not at that-
improvement?
We're not at that point yet. The bottom line, like I said, it's.
Okay, but my question is, well, we're not at that point yet because we still have some money, but if Dave's not sleeping at night, my gut says we're pretty close to that.
And you have to understand CFOs, we worry a lot.
You know
About
what?
a lot of things, that's right.
And you know
Uh,
what? And
I've got one
appreciate
model
that.
out there that says we got enough money, but everything has to go right.
Yeah, like I
We
said.
have enough money if.
If,
We have enough money if. Well, I always have enough money at the beginning of the month too. If I don't want something or something doesn't break or something doesn't increase in cost or their food cost or gas
Sure.
cost or whatever. But
Right.
we always talk about, okay, this is going to be our stopping point. Well, okay, we're going to come to, but we never say where that stopping point is. Nobody
exactly.
has said, okay, you know what, if we're
Mhm.
over budget or if we're, 12% close to our budget or whatever, then we need to hold this because we keep spending 30, 40, 50,000 out of pop or 8,000 out of pop for a new machine, but we can't keep the upkeep of what the hospital and skilled nursing need if we're doing other things.
And it's hard to argue against any of those things. I've been complaining about the 260,000 line item that we added for security. And how do you argue against the fact that our staff need to feel like they're safe when they come to work? And
Oh, well, David, I understand that. And I'm not arguing against those costs. I'm arguing against the income. If we don't have it coming in, we can't put it out.
No, it's a good point. It's a great point.
And,
Yeah.
and if we keep trying to put it out and we're not doing what we should be doing for our
Mhm.
community to make sure that we're at least staying afloat. But when do we say, okay, my husband's good, like, hey, no more shoes, no more purse, no more because of. Who's going to say that to us? Is that
Well,
you, Dave?
well,
Or
what
is
I
that
like,
Tim?
what I like about this board is you guys are thinking the right way. Catherine, what you just said was perfect. We need to have the right kind of mindset to keep our eyes open. Now, we don't want to lose out on opportunities. If this building can be built, we need to move forward because it's a very important project. But at the same time, we can't do it with our eyes closed.
Dave, what if if the community were asked up front, instead of waiting until their back's against the wall and there's nothing they can do, and then they don't pass it? What if we went for the prop to give us 40 million or whatever it's going to take up front and said, look, we need this to go forward, and have a little better communication with them than before, because every indication is we're going to have to go to community, but to go there after the fact, after we haven't performed the way we could, it just seems like would be a more prudent thing to do is to go sooner while we can make decisions on maybe cutting back. Once we're in the middle of everything, I know it's 9 stages. Once we're in the middle of it, we're in the middle, and it's going to be hard to backpedal. So,
and that's why I just gave you the kind of presentation I gave you with 26 million in the bank and 3 million on the bottom line, because I don't want us to be complacent.
we need to have an income to go forward. That's fine. We can, once we spend that money, we're on, it's going to be a bitch.
Well, I think, again, part of that is what we say. We really need to go back and find out what's the real cost, and that's what we're going to talk about a little bit later when Bob
Right.
Mark
Okay.
will walk us through that. But, again, because I think that's really going to help define that argument for us, and, but by the same token, I think, we've got to be able to show the community that we have stepped up and that we've done some things ourselves while we need help from them. We're not asking them to go out and pay for the whole thing. I mean, I think that's a much better sell than it is of saying, no, we want you to fund everything, and so, no, here, we've got this money set aside already. This is the work that's been done already. We've got into
And
this.
Bob's working harder now too, so that'll help.
So
But we don't have, we're not showing how we're
Right.
going to be getting the income into the skilled nursing.
Well,
Where's
I think-
that plan?
I think Tim's right. I think we've got a good story to tell that at the worst, we can tell the community, hey, we've got 75, 80% of this covered. We just need a little bit of help. Even with mediocre numbers coming out of skilled nursing, we should be able to make it work with just a little bit of help from the community.
Feel
But you know.
You're not
that-
gonna,
that
you're not
might
gonna
be the
make this
approach.
project with skilled nursing revenue. Let me just put it that way, okay?
Tim,
Skilled- yeah,
Tim, I understand that,
yeah.
but we're not gonna make it without it.
Oh, I'm just saying, there's a whole bunch of things that go into this
And
equation.
I
SNF is
love,
important.
I love a good story as good as anybody else, but what usually gets me in the butt is
Yeah.
the moral to the story.
Absolutely,
So where's the
absolutely.
moral to this story? I'm concerned as I listen to Dave and I read the numbers and I look at the different things. What's the moral? I mean, as much as I want to see this happen, I just don't know that we're going to keep going forward with this building and prices are going to continue to go up, or we're going to find something else, because that's just the way the thing is. You go to the grocery store and you have a budget of, well, you're not meeting that budget because everything's just gone up. My concern is, how are we going to go to the community, but yet we're not taking their family into the facilities either?
So, if I can add a couple, my 2 cents worth on this conversation, it's way premature to be talking about going to the community. We don't even know how much exactly this is going to cost yet. We may have the money to cover it. We just don't know that yet. So let's figure that out first, and then we can have the sky is falling discussions later.
But it's
But in the
premature
meantime, let's
to
not
get-
spend all our money.
To be getting plans done, and to be getting permits for something we don't know if we can do it or not.
Well, the point is,
How much
you have
money
to have-
have we spent?
you
$1
have-
million.
You gotta have
you
the
have to
plans, know what it
plan to
costs.
know what it's gonna cost. I mean, you have to do that. There's just no ifs, ands, or buts about
Well,
that.
and you gotta plan to know where the money's coming from.
That
It-
goes right along with, all this goes together, every bit of it.
You'll be pleased to see it. Next month, I'm gonna give you the 7-year cash flow pro forma that tells us exactly what we have at the end of the construction project, with a list of about 100 different assumptions on how much prices are gonna go up, how much reimbursement's gonna improve, how volumes are gonna change. All those things have to go according to the assumptions. But if they do, right now, it does look like we've got enough to cover ourselves and to have a safe level of reserves. And it's the type of model that if once things go wrong and go different than what you thought it would go, then you can go back to the drawing board and you can tweak it, and you can make choices in other places that maybe you don't have round the clock security, maybe you only have a few hours, and you cut a little bit here and a little bit there, and then all of a sudden you can make that plan work again. So we just need to be able to make decisions, not in a vacuum, but data driven, that every decision we make today affects our ability to afford something 7 years from now.
That's a very good point, David, and I appreciate that.
And I wouldn't necessarily go back to the drawing board. I would probably alter that to say that we develop contingencies. Again, it's like I said, you have different thoughts. If this doesn't happen, okay, what are we going to do in response to that, and so forth. I think we need to have our planning at that level. But, like I said, some of the things that Dave's talking about are things that we actually are already putting into the budget. He told you that I'm working on the expense reductions and so forth. That's exactly what we're talking about. We're going back and modifying some of the FTE requirements for security and those kinds of things. And looking at eliminating the daytime security, because we still have enough staff around here. We don't seem to have those kind of issues then. So let's cut back on that and start some of these things now as part of our new budget process. So that's what we're talking.
Part of the reason we don't have those issues is because COVID's changing. So we don't have upset patients or family members not being able to come and visit. Is that part of the change?
Part of it, yeah. I think that, COVID clearly is where we really saw the uptick on the issues in the ER and elsewhere. No question about it. And so, obviously we need to continue monitoring that. I was just reading reports this morning. They think there could be another surge coming. We don't know yet. The issue, I think what they're saying is, while we may see a big climb in COVID patients, the fact is the majority of them will probably not be entered into the hospital.
Yeah.
Again, because the symptoms are so much milder with these later variants that are coming out. So again, it just, we have to kind of keep our eye on the ball all the time and understanding what's coming down in front of us. while we continue to work on these efforts to try to build that SNF census, we're trying to get that back up. We're I think at 47 right now. We got 2 going over. We actually have a 3rd one planning to go over, which will take us to 50. And just keep plugging away, as we get some of these staff. I know Sally's working. We've got graduating class coming up here, I think in June, end of June or July.
Dave, if we lose 8% a year for the next 7 years because of inflation, that 26 million we got might not be 26 million.
It's gone. Yep. So
Yeah.
that's why we have to be sober in moving into each. I look at the budget process very seriously every year. The month of May is probably my most important month because the way we set the budget is pretty much drives the whole environment of the next year on how we're thinking. And if we're kind of making decisions willy-nilly without respect for the fact that when money's spent today, it's done at the expense of not having the resources in the future. So, it's just good that we all get on the same page, the board, administration, and the staff and the managers to work together to figure out ways that we can prioritize because we can't do everything.
Right.
Well, one good thing from this, I'm sorry,
It's all right, Gene. Go ahead. I'll do it when you're done.
was that apparently the people you were just talking about, in Bakersfield,
Which one?
grand jury,
Oh, yeah,
apparently they watch our meetings
they do.
because they were aware of what Catherine and Fred and everybody's talking about. And they wanted to see, but that's cool. That's good.
Yeah, and being transparent and talking, I don't think it's a bad thing, even though it might sound like we're arguing. I think it's a good thing.
Yeah, absolutely.
It's not arguing. It's called open discussion.
Yeah, exactly.
But reverting back to open discussion, what I look at and what I'm sure Gene looks at being a business owner as well, when you go back to page 28, talking about, total gross patient revenues, you take that last 6-month trend. If you just do the math, we were operating at roughly just under 25%. Now we're operating at almost 29%. That's when you go, okay, our numbers are down, our expenses are up. How do we justify being 4% above where we were at 6 months ago?
Yep.
What is it that we're doing different? What are we doing wrong? How do we correct our problem areas and get back in line with expenses?
Yeah, and the analysis I did, it shows the vast majority of increase in expenses have come from the support areas, not the direct care areas. So we're putting a lot more emphasis in marketing and security in the non-direct care givers. So that's what I'm just cautioning the board, just to be careful when, because all the reasons to do what we've done are all good reasons, but it doesn't look, when you look at the final results on these pages, it doesn't look good.
How much of that has been our one-time expenses, like our big generator falling apart and having to go ahead and move mountains to get that up and running again? And
Yeah.
And the plumbing problems that go wrong, the specialists we have to hire to deal with the water contamination issues or groundwater issues. Are those factored in? Because
No, you're right. That's played a big role this last year. And Tim's also right. That's why we got to put contingencies in, that when new things crop up that we weren't expected, maybe we can't do quite as much as we thought we could do in other areas where we can improve quality.
All right. Dave, thanks for bringing this up. It's
Okay.
certainly, we need to know. And the board, I think, is being real conservative on this. Thank goodness. We need to be. We need to protect our resources. We need to protect the public's money and keep our doors open. So thank you. Thank you very much.
And thank you. And I'm really glad we're moving forward on getting the updated cost estimates. That
Can
was
I say
important.
one more thing on that before our demographics? We're getting a lot more young people moving in here. And our retirement people are not moving up here. So we're gonna have probably an average age of 50 years old within the next 10 years or whatever, 7 years. And there'll be regular and conventional insurance rather than the type of insurance we're getting the IGT funds from. So that's gonna happen because everyone that's moving in, Fred, you know, we deal with the people that's coming in, they're all younger. Not all, but a lot of them. So it's gonna change for us and our reimbursement's gonna change and be less. So.
The one thing I think about with young people, I think they're a little bit more impressed than us old folks when they see a nice new building. So I'm really hoping we get this new building built.
But they're gonna pay with conventional insurance, which we don't get any extra money for. We just get what we can get. And it's not enough.
Yeah,
Right,
no,
Tim?
those are all challenges that's why you pay Tim and I the big bucks.
Yep, yep.
People bring all their kids with them. So they need our support.
I don't want to get into that conversation.
John, you have one more?
Yeah, well, I mean, kind of to Gene's point that he was just talking about, you know, maybe as far as like the skilled nursing facility goes, you know, and I don't know what the trends are with how many elderly people are going into SNFs these days, but we've kind of talked about in previous meetings, maybe like mental health awareness in the SNF or like somehow dividing that up. Is there any, maybe that's an indicator moving forward with
We
the
could
younger
just rent the
people?
whole thing out and come out ahead.
But as a motel,
No, as a skilled nursing facility, somebody that wanted to manage it.
So all those conversations require people, and there just are not enough people knocking Sarah Ramos's door down to come to work. I know that we have behavioral health grants available, but the people are not there to work in those environments. I wish I could be more positive. When we started up a CNA program this last month, and that number is down to 6 when we started with 10. And this happens every time we've tried to do our own program where we lose CNAs from that program even before they get started. So it's like we're spinning our wheels.
Just know how to do it, you know.
I
we
think we
hire them
still
in-
need to offer the classes and still need to do what we can. But again, and we just had a hospital or had a skilled nursing center in Bakersfield closed down. They had to disperse some of their residents to the rest of the state. Some of those were not appropriate for us. We did look at several of those patients, but they just weren't appropriate for our facility.
See, Catherine, what you did by asking that question?
Yeah,
well, I just see like a lot of younger people, you know, like between the 20 and 40, 50, that demographic in the valley. And it seems like a lot of them that I see out on the street, I'm not trying to be stereotypical, but a lot of them just seem like they have behavioral health problems.
Yep.
Whether it's drug addiction or whatever. And I don't know if they would be, well, I mean, Mark kind of already answered that question, but I don't know if they would be.
You're gonna be.
Kern County, and Catherine may be able to speak to this as well, but Kern County hasn't disseminated a lot of that money out of their own general population in their area. So they didn't leach any of that money up to College Community Services or the hospital or anywhere. They just kind of kept it in their immediate area.
They are building 2 new facilities to house behavioral health patients, one for adults and one for kids. I understand that are going to be built side by side out in Bakersfield. So, I mean, so some of that is being addressed with some of those excess funds that they had. But clearly, even with that effort, not going to be enough with the magnitude of the mental health problem going on in Kern County or in California.
All right.
Yeah.
I wanted to move on, but I have one more question. And this is to Mark. You know, with the CNA program, it seems like every time we've had a session, we always lose a couple people before the program starts, and then we lose 1 or 2 more before we're finished. Should we be selecting more people to start each session with the understanding that we're probably going to lose a couple along the way?
Well, we still have to have applications.
That was part of the problem. We took pretty much everybody who applied minus maybe
Oh,
one who
really?
didn't pass their physical, but it's.
They have to pass the
Okay.
background checks and everything else.
Okay,
Mhm.
It's
So
getting
we're
tougher.
trying to take everybody in that we can.
okay. I thought maybe we turned people away,
No.
And people
Okay.
relate
Well,
to what
One
kind
or
of,
two, yes, that we knew.
but they didn't qualify.
Yeah, right,
Yeah.
right.
and I just recently hired a CNA who worked one day and she comes from home health and realized, whoa, this is so much harder than home health. Maybe this isn't the direction I want to go. So
Right, yeah.
it really.
She
was
walked out.
get in there and figure it out, you know.
Worked one shift and no call, no show, didn't come back.
Yeah, and that's a whole nother topic of this, because we've kind of talked about that a little bit.
Oh, yeah.
Where this healthcare, careers in healthcare might be
It's hard.
20 to 25 years from now, or even sooner than that. I
Yeah.
mean,
Exactly.
that's a whole nother can of worms, so.
Okay, all right, well, let's
Sorry.
wrap this meeting up. We'll move on to our new business item G1. This is the resolution authorizing amendment and restatement of the retirement plan. Mr. McGlue,
Yeah, 457.
page 58.
58, okay, wait a minute.
I think this is just the resolution.
Yeah,
First.
It's the resolution, a separate handout is the actual documents that. the resolution support.
so this, again, page 58. I think we're on.
And 58 of the regular board packet.
I'm just thinking,
So this was the two questionnaires, kind of fill in the blank forms that
Yeah.
accompanied the resolution. Okay.
okay, so I
Do
don't
I
know.
have
if we
time to read
Read
this?
this, yeah.
No.
So this is the 457B. The 457B plan is the plan where the provides the pre-tax benefits for the employees to donate money into their retirement plan. And so forth. There were some very minor changes that were made to the plan at the recommendation of the plan provider. I think it was that was Shannon that did that in concert.
Group.
Yes, in that group. They went through that line by line, both on this plan and the 401A program. Barbara Figueroa was a part of that. Barbara asked lots of questions and so forth, and all of these adjustments were made with Barbara's recommendations and support. And so at this point in time, like I said, it was recommended that we go ahead and approve that plan, which is
One of the things I was looking at said profit sharing plan. Make a profit.
No, those are governmental terms that they use as a standardized form. And so we weren't able to change the headers on those because that's a standardized form that they use.
But the
with
government shouldn't
our
allow it to be,
457
to
falls
say they
under.
can make a profit because they never do.
Yeah, if you want to fight that one, I'll give you their number. I asked the question too, and she offered for me, and I said, no, thank you, I'll give that to Jean.
Now, apparently we have a deferred compensation plan also.
For,
for the retirement plan. There's two plans. There's basically the ones that the employees contribute to themselves.
Mhm.
And that is this plan, the 457B. The other plan is the 401A plan, which is a government plan that basically allows, that's the one the hospital matches that money against. And so like I said, there were minor modifications that were made here. Sarah has those if someone's interested specifically in what changed. Like I said, I got with them and went through those again. And again, relatively minor things.
I can give you a quick brief breakdown of it.
brief,
So
just- I
basically,
think
it was just being able to pull the money that the hospital contributes to the plan prior to retirement or prior to reaching your 5 years, 100% vesting. So we changed that even if you retire, you come to retirement age, prior to your 5 years, you don't get the 100% of the vesting.
Right.
So we changed that, and then we we removed the 1,000 hours of service because that's being calculated through payroll. So really everything, once you changed one, which it was the vesting to the 5 years, it changed a couple other things with the ages of retirement age from
There was
59
just
and a
a few
half.
vesting changes and a few things like that. There's not
Yep.
really any change.
There really is. The
No,
plan
it's
is
just-
pretty much the same as it was
Yes,
before.
it's pretty much just all the age requirements to be able to have to go through our vesting, which is the minimum of 5 years to be able to get 100% of the hospital's contributing match.
Right.
But this, I read somewhere in there about deferred compensation, and that's where you can take and just not get part of your money and put it in the bank.
Yes.
And do we have
I
that?
believe there was a provision, if I recall. I do remember reading that.
And then you get it specified after you retire so many years or in a certain way. But it's okay. It doesn't make a lot of difference if it's in there. It's been in there, so it's fine.
Yeah, that part didn't change, right?
Okay.
That, none of that changed. The only thing that changed was the cash out distribution threshold and the age
To
requirement.
move it along, I'm gonna make a motion that we accept it the way it's presented.
Okay.
And I have the changes if you want to go over them afterwards.
I've gone, I went over the whole thing.
Okay.
I don't know why.
We have a motion on this resolution. Do we have a second? Fred seconds. Any more discussion among the board?
We want to waive the reading of the resolution.
Is that something we
Yes.
need to do?
That's part of the motion.
Does any member of the public wish to be heard on this? Okay, then we'll vote. John, your vote?
Yes.
Fred?
Yes.
Jean?
Yes.
Catherine?
Yes.
And I'm a yes. Okay, and item number 2 is resolution 2208. Resolution of the Kern Valley Healthcare District Board of Directors for the adoption of the Kern Valley Healthcare District Cafeteria Plan. 9 in your packet.
I've got a question on the health insurance.
Mhm.
We have a lot of people, employees that are over 65. A lot of plans require them to get Medicare. And then we could pay for their Medicare, the 200 or $147 plus their supplement. And they would have no deductibles, no copays. It would be better for them. Why aren't we doing that?
Good question. If that's something we want to look into, we can, but as of right now, I don't know that it's ever been brought to anybody's attention.
Okay, it would be a benefit for us and them.
Yeah.
Because they wouldn't have any out of pocket at all.
Right.
And so if we could find out if we can.
Maybe not
change-
understanding how those plans work, maybe it's education. And I think that's where we probably need to start with educating the people that are above that age.
Yeah, well, if we first have to require them to do it. And so it's
Again,
something that we should look into because it could help us and them.
sure.
Mhm.
Well,
So,
like I said, one is obviously the plan itself, which we'll talk about that because that's the next subject after this cafeteria plan. The cafeteria plan obviously is the plan where our employees can go in using pre-tax dollars to
Yes.
enhance their benefits for life insurance and for certain other healthcare benefits, spending account, government spending accounts and those kinds of things. And so, again, the plan is here as well as the summary plan description. And again, with changes that are made here, once this is approved, then immediately all of the employees get the new summary plan description explaining what's changed on there. So is there anything specific you want to
No,
talk about? with
nothing
this?
actually really
Okay.
changed. in-
I've read,
It's a free statement.
to move it along, I'll make a motion again that we
Yeah,
approve it as
nothing changed in the
presented
cafeteria plan.
on the cafeteria plan. It's
Right,
It's just confirming that we're going to continue allowing them to pull pre-tax.
correct.
Now, the issue that you brought, so we have a motion. Do we have a second?
I'll second.
John, thank you. For discussion on this motion, and Jean, is that option that you had just talked about?
well, it's not
That's not this,
It's not
it's
part
the
of
health
this.
insurance.
Okay,
That's
all
the
right.
next, that's the
Okay.
next thing we're talking
further
about.
down the road.
Okay, all right.
I just,
Yeah, it's actually a good point,
Okay,
really good point.
all right, so bring that back up. In a couple of items down. I'm curious about that as well. Are there any questions or discussion on the motion and the second for this resolution? Any member of the
No.
public wishing to be heard? Okay, Jean, your vote,
Yes.
John,
Yes.
Catherine,
You're
Yeah.
muted.
there you
Can
go.
you hear me now?
Yes,
Okay. Yes, and my vote is yes.
thank you. Fred,
Yes.
and I'm a yes.
Okay, great. Thank you.
All right.
Still in the meeting. I'm hoping you are.
Okay, then item 3, the RFP for integrated cost management services, Tim.
60. So I'm gonna go ahead and turn this over to Bob. Like I said, we discussed, again, we've talked about it for some time, I think in building and planning and so forth. And I think we're at a point right now that we finally have a set of drawings, that have been submitted to OSHPA. Those are in plan review right now. It'll be probably a while before we get that first review back, which will kind of tell us how close we are on the right track or whatever. But the fact that we now have those drawings and stuff like that, I think it's probably time that we go back out to look at getting this repricing. So this is in effect a request for proposal to request outside services to come and bid on an effort to go back and do that work for us. So Bob, do you want to take it from there?
Yeah, so, yeah, because, we put a number to this project quite a few years ago, and we have not even given it a percentage of increase per year. So yeah, everybody feels that it's time. So I pulled together an RFP and I sent it to Scott, and Scott went through it and added some very good items. They were highlighted in yellow on my copy. They probably came in slightly gray on yours. Anything that's slightly grayed was everything that Scott added. And so it's been through all of the, blessings for that. And so, yes, we'd like to send this out. I'm kind of thinking that we would post this, and probably for responses, I'm thinking in 2 to 3 months. At least I don't know what everybody's feelings on that, but you got to give people time to be able to look at the plans enough to be, because all we're asking them to do is to give us a cost, to give us cost accounting for the master project. So obviously it would be a fee that we would pay. They would then delve into the plans in detail and put construction costs to each of the phases, and then give us a report saying this is what we believe your costs will be for construction costs and soft costs and anything that, anyway. So this was actually done a number of years ago, but it was back when the project was a completely different scope. So the costing that we have done over the last few years has been basically taking the numbers from the firm of 4 to 5 years ago and kind of bringing them forward to give us a general idea. But that was back when we were going to have an MOB out here and a new building on the lawn and that sort of thing. So we feel it's time to get a finite pricing from a good firm that specializes in hospital construction cost management.
Are we submitting a request for them to give us a bid? Or are we just posting it and depending on them to look at it?
The requirement is that it is posted.
I know that's a
Yes.
requirement, but
Doesn't mean that we can't approach some firms and say, hey, this is out there. We would like you to take a look at it and, hopefully be interested in
wouldn't
bidding.
that be a prudent thing
Scott,
to do?
Scott, is that acceptable?
Can't hear you, Scott.
No.
No,
No, the audio's weird.
Yeah, your audio is not good.
get closer.
Yeah, it's better.
You can hear me?
Yeah, we can hear you breathing now.
We can hear you too much now.
All right, I'll stop with the heavy breathing. Sorry about that. Yeah, so having 2 or 3 or 4 firms who you're familiar with their work, and sending the RFP directly to them is very common, and it is acceptable. It would fall within the parameters of a fair and competitive selection process. And then you should also post it on the website as you've discussed.
Okay, just wanted to make sure that was acceptable, because we will obviously approach the firm that did it 4 or so years ago. And then I got some recommendations from our architect of firms that have worked for like, what's the big hospital up on the east side?
Don't say Tehachapi.
No. East side, no, not Tehachapi. But he was very impressed with the firm that was hired by,
Ridgecrest?
no, further up.
This year?
Oh, I saw that in you.
No,
Northern-
further up. Mammoth. The Mammoth has a big new project they're starting, and they utilize the firm. So anyway, and they had actually reached out to a number of firms. So they all have given proposals. So we have the names of 3 additional firms in addition to the one that did our work. And so I wanted to make sure Scott was okay that I contact them directly once it's posted on the site, so that they know it's there and can bid it.
Yeah.
Under those conditions, I make a motion that we approve moving forward with it.
Okay, Gene. Do we have a second?
Definitely, I'll second Ross.
Thanks, Fred. Okay, so more discussion on this. Do the board members have any more questions or comments on this item?
I'm just looking forward to getting an accurate number.
Yep.
Absolutely.
Me too.
And we'll have more questions as we get someone who's interested.
Sure, betcha.
Yes.
Now, what did you anticipate as a time frame for putting this out and then waiting for the replies?
Well, Scott, what have you seen in the past? I'm thinking a minimum of 2 months.
So yeah, usually I see 3 to 6 weeks. Depends upon the urgency of the project. But 2 months is on the long end of what I normally see for these types of projects.
Okay.
Especially since this isn't design, this is cost management services. So I think if you did 4 to 6 weeks, you're going to be okay. And then Bob, you and I can talk a little bit more about this and some of the sections that were highlighted in yellow that we didn't have the time to get to, and just finalize that, and then we can send it out. Okay. I would say it could go out within the week and be posted 4 to 6 weeks.
All right.
Dave, you trying to get some attention?
Yes, it would be important to me as well if, for example, we could maybe get some numbers back in early July, right after the new fiscal year with the, this new budget, I'm really looking at as being a starting point of keeping us and getting us on track toward being able to afford whatever the new number is. And the sooner we get that new number right around the same time as we approve the budget, the better, as far as I'm concerned.
No, we will only have the number to give us the number.
Yeah.
Yeah, and then there's more to come. Can I make a comment? I don't want to hurt anybody's feelings, but I hope we are paying Scott what he's worth.
Is that supposed to hurt my feelings? Am I the one you're talking about?
Watch those fingers as he touches his shirt.
Okay.
Yeah, I certainly think 4 to 6
And I'm
weeks.
good with like 4 weeks.
Yeah.
I wasn't really sure. I've not actually put out an RFP for this kind of a thing before, because a lot of the big projects I did were design build and they were preset by corporate.
And we're not asking.
The issue is your proposal is to get people to bid on it, so you've got a time frame built into that.
Yeah.
And then they gotta go do the work on top of
Yeah,
that. That's gonna take some
they
time.
will give us a time frame of how quick they can get.
We're not asking them to do the work. within 4 to 6
Right,
weeks.
right.
And we'll approve the ones that say they're going to do it.
Exactly.
Yes.
Yeah.
Exactly.
Yeah, those will come back to the board, right?
Yeah, they will be a written proposal of what they will provide and what the costs will be.
The top couple, 2 or 3, something like that.
Yeah.
Okay.
Yep.
Okay. Does any member of the public want to be heard on this item? Okay, are there any more questions or discussion? Okay, seeing none, then we'll go for a vote. Jean,
Yes.
Fred? You're muted.
Sorry, my fault. Yes.
Thanks. John,
Yes.
Catherine,
Yes.
and I'm a yes. So please move forward. Thank you.
All right. I'll
This
work with
looks real
Scott.
good.
I'll work with Scott this week.
Great.
Yep.
This looks real good, Bob.
By the way, I have the architect and engineers here for 8 hours on Wednesday going through minutia related to this whole project.
Okay, great.
It'd be good to tap into them while they're here too.
Yes.
Yeah, and the broader you can, audience you can reach with this RFP, the better. So that'd be great.
Yeah, I'll probably, I may approach also, because I'll use the usual one but there's also, I'm trying to remember the name of them, but one of our other projects, we posted on a much larger website that goes out like literally nationwide. And we could do that one as well. I mean, I can approach them and see if they're willing to put it on.
But you're more than likely to get better results from somebody that knows California market. Right?
Yeah, I agree.
National firms. So.
Yeah.
Yeah. Okay, item 4, employee benefit program. Janet.
Okay, it's just, again, time to renew our employee health plan. In doing so, we wanted to make sure that we went back out to the market just to validate, one, what it would cost us to go outside. Secondly, even to see whether or not we could get somebody outside. It's very, very hard to ensure healthcare organizations just because the employees have a tendency to be overutilized at times. Anyway, to stay on our current plan, which is Cal Choice, which is a consortium of a bunch of small employers throughout the state of California. The bid to renew that program that we have now is 4%, which year over year is a great price. I mean, it's incredible. The nice part about Cal Choice is that it is age adjusted so that our younger employees pay less than the older employees. So it makes it easier for them to afford to get on the plan, which is exactly what we want them to have. We want them to stay healthy, we want them to stay working. And it gives them a choice of plans. I mean, again, we've got our employees fall into primarily 3 major groups. Even though there's probably about, I think there's maybe 8 or 9 plans to choose from last time. They fall into the Anthem HMO, they fell into Kaiser, and they fell into the Anthem People. And then there was 2 other plans. We had a small health net plan with 2 people in it, and we had another United Healthcare with 1 in it, and so forth. And so, but we went out to Aetna, Blue Shield, Health Net, and UHC, and they all declined to quote. Blue Shield mentioned that, again, extremely high prescription utilization, underwriting rates came up and 45% over current. So again, we do have employees who are on some very expensive drugs and so forth. And so that may have been one of the factors that entered into this. So, again, Anthem proposed, again, if we wanted to move everybody to a straight Anthem product, their prices are in here. It is still an increase of about 5.92% if we went that route. And so forth. What you do though, when you get into that is you kind of then label everybody into a single plan. And everybody would then have to move off whatever plan they were on into Anthem. And so, which then really totally disrupts everybody, and what their use and their utilization plans and their doctors and these kinds of things. And so, our recommendation was primarily to kind of stay with Cal Choice. The issues, like I say, we're extremely lucky to get into that in the first place. It's primarily a group that is made up of businesses that are 50 or fewer employees. We went into it with over, I think it was just over 100. And it was primarily because, again, our broker had great relations with them, that they allowed us in. If we come out, we'll never get back in again. We know that, been told that, and so forth. So, like I said, as long as we can continue to provide the choice, provide age-adjusted benefits and those kinds of things, and our increases stay reasonable. Most everything else has been double-digit increases that most people have been experiencing.
9 to 13%.
Right, and so And a matter of fact, if you go to another plan that is not age adjusted, the people that are going to be impacted the worst are going to be your younger employees, because the seniors are all going to have their rates drop to the blended rate and so forth. And so we just didn't see that that was something we wanted to do right now. We wanted to keep the rates affordable for everybody. So
if I'm reading this right, then the Cal Choice option, the renewal is
4.4%.
least expensive and provides the employees the greatest
most
choice.
options.
That is correct.
Okay.
What's the renewal on it date?
July 1st, yeah.
Do you think you could look into, I think it's probably the only thing to do, look into, even if the employee over 65 opted out completely, we could give them something to opt out.
Well, you got a good point. And again, I think what we need to do is this needs to be an education issue for our employees. And we've got time before our open enrollment period where we bring somebody in to talk to them about getting on a Medicare. I mean, you and I have had that conversation because I'm on the health plan. Even my broker saying, Tim, what the hell? Why don't you change and get off on a Medicare? I'm going, so I just don't know enough about it. That's why I've stayed on what I'm used to.
She will and does, and they will.
Yes.
So, okay.
That was exactly what.
And
I
then
had
if
said
people
too, is
choose to
follow
go
the
that route,
education.
then that just means fewer people will enroll in the plan, which will drop our costs.
Right.
And if we figure out a way that we can somehow augment that, we can come back to the board and
Right,
ask
we
for
can
help.
maybe give some.
But, yeah.
And with that being said, also I can reach out to Mike today when I get back to the office, because he did give us the option to be able to put together some type of slideshow for him to be able to go over things with our employees at open enrollment, which will be the week of the 23rd,
Yeah.
25th, for a whole week. So that may be able to something that I can, if you have any information you could provide to me that I can put together in a slideshow and give to him to present to those employees, that would be great, because like I said in the beginning, it is an educational thing, and a lot of the employees may not know that those options are out there for them.
And we should
So,
let them make them aware.
exactly agree.
And like I said, he's all for it because he's on straight Medicare plan himself, and so.
Well, and
Then-
and I just have a question, since a lot of you are in this kind of same boat. Okay, I just signed up for Social Security. But I opted out of Medicare because I'm on the hospital's
right.
plan and I'm going to be for a number of years. But
Well, you still took the Medicare hospital plan, the Part A.
oh,
Part B.
yeah, so they just sent me my card. So I have a Medicare Part A
Right.
hospitalization
Same
card.
here, same here.
Okay, so that is normal. That, in other words, yes, I still am on the
And it
hospital's
can
plan.
make a difference if your wife needs the coverage too, or if it's just you that needs the coverage.
She's already on Medicare.
Yeah, okay. So then this could apply,
You, yeah.
what
it's a great
she's
thing.
talking
Yeah.
about,
Yes,
this could apply to you.
Yep,
So,
exactly.
okay.
I make a motion that we accept as proposed, and you're gonna look into.
And do you have any, like I said, any literature, anything that you would like to send over? I'd be happy to take that and look into putting together some type of
Okay,
slideshow.
he'll know exactly.
Yeah,
It's just boilerplate. It's just the way it is.
Yeah. we
He's
talked.
already told Bob what the best way to do it, and
Okay.
Bob don't listen.
Well, Bob also doesn't do our open enrollment.
I'm
so-
listening.
Say, this Bob?
No,
No, Bob
you
also-
meant me. I know what you're talking about.
He
All right,
also
I'm
doesn't
going.
do our open
I
enrollment. We
missed
have a
something
company
there.
that
He
does
knows
it for
I-
us, so they would
Looks like
need to
Bob
be
Bibbins
provided
is
with that.
Yeah.
information.
Bob could do that.
Yeah, okay.
What month is the open enrollment?
It's at the end of
End
this
of May,
month.
yeah.
It's in May.
Yeah.
Okay, all right.
Yeah, because we
Yeah, it
need,
takes time to build the paperwork out for June and to start July 1.
All right.
yeah.
So then there's a couple other
And then we
changes
need to notify payroll and all that.
that go along with this. I don't know if you want to go ahead and take a vote on that motion
Yeah,
first.
let's leave your motion hanging there for a sec.
Okay,
Because we've got-
it's in
Yeah, There's
discussion.
two other
Couple other
pieces,
options
two
for-
or three other
Couple other
pieces. to talk
benefits
to.
that.
One
we need to
was,
vote on.
we offer the basic life insurance, accidental death and disability coverage for our employees. That's hospital provided. And so again, they offer for class 1 and 2, which is all eligible, non-exempt employees plus board members. And they would qualify for $25,000 each for insurance. And then class 3, which are the all eligible, other eligible, which are the exempt employees, would be 1 times annual earnings until you reach a certain age. Then it drops, I think it's 65 and drops at 70 again. And so it drops it to 35% at age 65 and it drops 50% at age 70. So issue here is we're currently on that first column, which is, it says New York Life. That was Cigna, and it's been Cigna, but New York Life just bought out Cigna. So that's why it's changed. So, but you can see that we're paying right now at between 11 and 12 cents on the life insurance per $1,000 of coverage, and then 2 cents per 1,000 on the AD&D or the accidental death and disability rate. So we're looking at about $11,000 to $12,000 per. This is per month.
This is annual.
This is annual. Okay, annual.
This is
Okay,
annual.
right. The proposal was to go ahead and switch to Mutual of Omaha. Same exact coverage, 25,000 one times annual earnings, same percentages and so forth. The difference here is we're paying 8 cents per 1,000 on the actual life insurance. The accidental death and disability remains the same at 2 cents. So it drops us from about 11 or 12,000 bucks a month down to 8,600. So save a couple $1,000s a year, and that was the recommendation. It's about a 23% reduction.
So that's in the
Overgrown.
proposal.
That's in the proposal. Yes. And then the next was the voluntary life, and this is, I believe, is totally employee supported. And his plan here, we're currently again on New York Life. He was recommending, again, we switched to the Mutual of Omaha. And so price wise, it's pretty much the same. And so there really isn't a big issue here. I'm not sure on this one. Again, so much of our other stuff is covered on, this is under Colonial, or no, it's still Cigna on the insurance here. So.
This,
Or New York
Good.
Life.
this one here, we also offer this through Colonial though.
Right,
And so we were gonna, in order to participate in this, we had to have 25% enrollment.
25 to 30%, 30% of it's Mutual of Omaha.
So we were just gonna stick with the current.
I think we were gonna stay with our current one here, which
That
is
is correct.
Colonial.
Mhm.
Because there's a lot of other benefits that Colonial offers as a part of the cafeteria plan, which we talked about, like cancer care programs and some of these kinds of things that people can take it out on. So don't know that I would switch on this one. I would on the life insurance that we provide in the AD&D. But for the ones that the employees can buy, we're better off, I think, staying with where we're at here. So
And just to throw it out there, Colonial is more like an AFLAC, so they offer a lot of different plans that the employee can choose to purchase if they would like
right,
to.
right. So there we're just gonna stay with current. And then the last thing they asked us to take a look at was, again, a number of companies will offer a long-term disability program. This is currently, they're proposing an employer-paid plan through Mutual of Omaha. This is running at about $3,300 a month or $40,000 a year. You know, a bunch of us talked about this as to whether or not it's a good thing. It is a new benefit to offer the employees, but so few employees actually take advantage of this, primarily because this is really affecting those that are out on disability for an extended period of time. It doesn't even kick in until 6 months. Otherwise, you're covered under short-term disability for up to a year and so forth. So in essence, you're paying $40,000 a year for just a couple of individuals who might get to that point where they would need that and so forth. The employees have the option of buying in as a part of their cafeteria program today through Colonial. They can buy long-term disability themselves if they feel like that they're at risk or whatever. So our recommendation was to not do this year. Again, it's never been offered by us before, so we're just not going to go.
So if we approve that packet, we're approving not to do that.
That is correct. That would be correct.
The employees just not take advantage of it because they just don't know much about it. Is it an education situation that we were just talking
Well,
about?
as far as that, the long-term disability plan is, if they purchase it through Colonial, then that plan can be traveled with them if they were to go out on any type of leave. Currently, FMLA, you get your leave 3 months, and then you're no longer with the company. So we're paying for a plan that in all reality, they can't transfer with them at the time of their voluntary resignation, or because of FMLA, this plan would be no longer of use.
Right.
So their best bet if they did want the long-term disability plan would be to purchase it through Colonial, and then that plan is transferable with them whether or not they work here or not.
Right.
Okay, gotcha.
So that was our plan, is to stay with the current plan that we have, allow them to purchase them themselves instead of having the hospital provide that benefit
Okay.
at our expense, right?
So was that the last part of it, Tim?
Yes.
Okay, so the motion's still the same, there's no changes, because it was all, they just
Stay with
explained
current.
it a little better.
Yeah.
I read it, but
We're gonna change, we're gonna stay with the medical, we're gonna stay, we'll switch the life insurance to Mutual of Omaha, and then everything else stays the same,
Yeah.
Colonial.
Okay.
my motion still.
Thank you, Gene. Do we have a second? Thanks, John. Any more questions, discussions on this item? Any member of the public wishing to be heard? Okay, then we will vote on this. Gene,
Yes,
John,
Yes.
Fred,
Yes.
Catherine,
Yes.
and I'm a yes. So we are at item H, director's comments.
but
Yeah.
we didn't have something to approve finance or copy or nothing.
What's that?
That was all done on consent. You had that
Oh,
on
okay.
consent. You approved that already.
Do you have comments, John? We'll start with you.
Since I got my
We'll start
mouth
with
open,
you.
you're gonna, I just, everybody that's involved in the employees' compensation, I know we're not overpaying anybody except Tim. And
I disagree.
and
I'm grateful.
whatever we can do to help them along, we need to make every effort to swing things in their favor. That's my opinion, I guess. And I was joking about Scott. He shouldn't make an enemy out of a lawyer.
Scott, do you have any closing comments today?
Well, thinking about Director Parks, no, I don't. I'm good.
Okay. Director Blythe?
I don't have anything today, Ross.
Okay.
Thank you to
All right.
reiterate a lot during the meeting, so thank you.
Fred? Director Clark?
I think that we're finally getting out to bid for a current number, guys. Thank you.
Yeah, that's exciting. Director Elkanan, any comments? Any closing comments?
I do not have any closing comments. I do appreciate all the information, though.
All right, well, thank you all. So I see that it's hospital week
Yes.
and that's, I want to celebrate all our people that make this hospital such a good thing. So thank you to all our wonderful staff.
We got activities going on all week long.
That's great.
I think today they had ice cream, price.
Today was ice cream sandwiches and Western Day. So if you wonder why
I didn't even
everybody's
get down there
wearing
for
their
it,
cowboy boots.
Excellent, excellent.
And there's a lunch, and what day is the luncheon?
Lunch is on Wednesday and then on Friday, we're
Is that what
doing.
we're serving?
succulents.
Yes.
The board members are serving on that?
Yes.
Yeah. Okay.
That's the 11th, right?
Yes.
I will be out of town, I'm sorry.
Okay, too bad.
Good morning.
I like having food fight with you.
And for you, it's the 12th.
It's 12. Oh,
For you, it's the
oh.
12th, that's right.
So I attended a presentation at Cal State Bakersfield on Saturday. It was a health administration class. And so it was lower division and upper division combined class. And there were 5 presentations, and one of the groups that did a presentation selected Kern Valley Healthcare District as their, I didn't figure you'd do about it.
Nope.
As their topic. And so they gave a presentation on how to improve STD instances or STD rate and teen pregnancy. It was fascinating. And they basically presented a proposal. I don't have it in writing yet. I just watched their PowerPoint on how to implement a program like that actually pays for itself over 5 years. So as I get more details, I want to share it with the board members, share it with you.
Yeah, but
It was something that, it's a student perspective. They don't have the real life experience yet. But the numbers worked.
Yeah.
And so it might be something worth looking at, maybe to benefit our community.
but we know that, yeah, there was a report a number of years ago, Mark, if maybe you recall, where we had one of the highest rates of STDs, I think statewide, if I'm not mistaken.
I believe it's still the
It's
same
still
with certain
bad,
ones in
yeah,
Kern
yeah.
County. They
I
just
know.
didn't.
I didn't either.
Wow.
It's still bad.
Scary, very
And
scary.
even teen pregnancy too. I didn't think that was rampant, but apparently it's, our numbers are stand out compared to,
Wow.
Interesting.
Other places.
so, yeah, it was worthwhile. You know, these young people really obviously put a lot of work in on this, and it may be something that one of those programs that we hadn't thought of that might provide a real benefit and actually provide a little revenue to the district.
Might be helpful to see if we can get our hands on the data that they put together, because, you know, again, I know when I went through my program, that we had to do programs like that were ultimately then put out to the community to see. And the one I did with my team was ultimately picked up by one of the health companies in Arizona. And they actually went out and did that one. And so, because you did a lot of their legwork for them.
Exactly.
You know, it was
Exactly.
great from that.
So just for the record, I had nothing to do with either one of those topics.
Well, I've been saying since I started here, that one thing I think is really important for our hospital is to reach out to our community and to our youth. And I know I've talked to Debbie about it, and but getting out into our high schools and letting the kids know that we're here and what we have to offer and how they can utilize our services with or without adult consent, because a lot of things they're able to do. And I just don't think that
Sarah, you missed out on the CSI Momentum project that Alex and I put together.
Oh, yeah.
That was a pretty impressive outreach to the community.
Very
Yeah.
well received by the community.
so I definitely
Well, I was
think that that's important.
I was gonna say on that point, maybe that's something that, you know, what the work that Lisa Wiley and Heather Berry do for the district, maybe that would be something for them to educate the youth on with
Absolutely.
teen pregnancies.
Well, and again, since we've got our mobile clinic going out to the high schools and stuff anyway, I mean, there may be opportunities for us to pick up some of that. I mean, Greg, I don't know
That's,
if you're hearing or seeing that from the
Yeah.
school districts or not, or,
We aren't doing any those types of programs right now.
you know,
Nothing.
is there anything you're hearing through the school health programs, though, related to other issues going on in the schools or?
No, not directly. The program that Ross is talking about, Cal State contacted me about that. I said, I'm open to talk to them, and they never called back.
I'll be darned.
We're not sure how much what they really want to do, if it's beyond what, it's not one of our QIP measures right now, but potentially could be in the future.
Okay.
the gist of what their proposal was is basically partner with the high school, provide services on the campus through the mobile clinic, allow the students to access those services and build the relationships with their providers, us.
Yeah.
And so not only solving their problems now, but then they become patients when they're adults. And
some of that was the reason why we did that. Again,
Yeah.
when Greg first brought that to us about, getting the mobile clinic. And the partnerships with the school was to begin, and we did the work with the health plans with Kern Health and with HealthNet, obviously, to allow them to pay us for seeing patients in the schools, even though they may be assigned somewhere else.
Right.
And so forth, so that we actually have that ability to do that.
I could see that morphing back into an ECHO program that focuses on careers in healthcare.
Right.
Maybe. Anyway, I'll share when I get my hands on the information. I'll-
Yeah, no, it'd be
I'll share
great
it
to
with
look at
Greg,
it.
and you guys can take a look at it and see if it's something worth pursuing.
Great. That's good.
Okay, so thanks for offering 2 cents on that. Appreciate it. We are adjourned. We will meet again next month. Thank you all.
Thank you.
Thank you, everybody. Have a good day.
Thanks all. Take care.
Simplify stuff.
Thanks for this.